Welcome to part 3 of the podcast on airway equipment and adjuncts. This slide shows details related to endotracheal tube sizes and lengths and recommended lengths or for oral insertion, nasal insertion, recommended suction catheter size, etc., etc., etc. So there are a lot of details that are not entirely um, obvious when it comes to endotracheal tubes. Now, changing topics, let's move to the top. Straight blades are better for children. It's common wisdom that the straight blade is the preferred blade for children. This was apparently never proven, and as recently as 2013, a study was proposed that would answer this question. The sponsor was the State University of New York at Buffalo, and the responsible party was Gerald Lehrman at the State University of New York at Buffalo, previously an anesthesiologist at the Toronto Sick Kids Hospital. Now, Dr. Lehrman and his colleagues designed a study that was meant to answer the question, is the size 1 Miller blade truly superior to the Macintosh for laryngoscopy and intubation in children less than 2 years of age? And in order to cut to the chase, I'll give you the conclusion, and there's the use of is a complicated study that involved taking photographs of laryngeal glottic openings and calculating the percentage of glottic openings, calling that the POGO score. But for what it's worth, and I think that there was the opinion that the Miller blade was truly superior. Perhaps there is a bias in this study, and it only resulted in the conclusion that it was what the authors wanted to believe. Nonetheless, in the hands of the investigators, they could not conclude or prove that there is a significant difference between a Miller and a Mac. Now, anecdotally, where I trained, even though we did use some straight blades for children, there were a number of pediatric anesthesiologists who used Mac 3 in small kids. And if you think about the size of the head and tongue and airway in a child, at least relative to their age and weight, it's not impossible to use a Mach 3 in an atraumatic fashion, because in fact the force that you're transmitting to the base to the tongue or to the vallecula or whatever is in fact distributed over a wider area if you use a larger blade than a smaller blade. But for what it's worth, a recent study comparing these two standard blades came to the conclusion that the Mach 1 blade yielded a superior laryngeal view if it is used to lift the base of the tongue rather than the epiglottis. In other words, using the Macintosh blade in the way that it was designed. Now, a recent but not quite as recent study, Canadian Journal 2003, attempted to answer the question whether or not straight blades improve the visualization of the larynx compared to the curved blade. Well, the conclusion was revealed in the title, and the straight blades improve the visualization, but curved blades increase the ease of intubation. This study used some equipment which most of us have never seen. I've never seen a Lee FiberView blade, and depicted as number 1. I've never used a McCoy laryngoscope or laryngoscope blade. I have seen blades with prisms, but they're kind of replaced by video laryngoscopes now. And the classical Macintosh is depicted in number 5. And this is the summary statement should fall into what you all have observed over the time that you've been learning the skills in anesthesia, is that a good laryngeal view doesn't always equate with an ease of intubation. Sometimes it's just awkward or difficult to get the tube to advance through the glottis, even though you have a good view of it. So it's another study that, at least in the hands of those who have attempted to compare straight blades to curved blades, the curved blade appears to improve intubating conditions. Now, I'm proposing that you look at this book. The editor is Cummings. It is a textbook in ear, nose, and throat surgery, otolaryngology. And this chapter in Cummings has a slightly different view, and a non-anesthesiologist view of some things, and has some nice summaries, which although this particular slide is hard to read, it does summarize the various airway devices, starting with the most basic face mask, and the most rudimentary intubation technique, which is digital, meaning you use your fingers, and going up and down the gamut. Now, one of the reasons why I bring this textbook to your attention is that, in the view of an otolaryngologist, a suspension laryngoscope like this one, which is called a Hollinger laryngoscope, or maybe a Dido or something like that. But in other words, this kind of laryngoscope, which is used by otolaryngologists, not by anesthesiologists, is, in their opinion, the difficult airway laryngoscope. And indeed, in patients with abnormal airways, cancers, and such, sometimes this laryngoscope is successful when nothing else is successful. So this is worthwhile you knowing about. Whether or not you will ever become skilled in using it is debatable. This is a zoomed-in version of the table a couple slides back, much more easily read, and summarizes, the various airway devices which we use: a face mask, laryngeal mask. Blind nasal is not a device. It's more of a technique, digital likewise. If you seek the techniques for digital intubation, you will find them. There's some descriptions of digital intubation of the airway in some airway texts. The lighted stylet, also known as a light wand. Conventional laryngoscopy is what we do most of the time using Macintosh and Miller blades. And other things such as the Ashman, the Frova, the Aintree, all of which I've made reference to in this podcast, are referred to in the bottom of this slide. The next slide brings up rigid laryngoscopy, the Hollinger, as I've mentioned in previous slides. Hollinger is the difficult airway scope. Rigid bronchoscopy can be a technique used to access the airway and provide oxygen. Fiber optic bronchoscopy you're well aware of. Rigid fiber optic bronchoscopy, the Bullard's laryngoscope, the Upshur, the Wu, none of those are in frequent use anymore. And finally, retrograde intubation involves the passage of a guide wire or something like that from the neck up through the mouth, and there are retrograde intubation kits which are available. I think can be found here at UK. Not a technique used very often anymore, but in the days before fiber optic bronchoscopy, retrograde intubation of patients with cervical spine injuries was often a practice. Carrying on, percutaneous cricothyrotomy, tracheostomy, transtracheal jet ventilation, other devices are in the repertoire. And as I've already alluded to, the Ashman tube, tracheal tube introducer, I just, for your amusement, bring this letter in anesthesiology to your attention, and it's the opinion of at least one correspondent that the Ashman is neither gum elastic or a bougie. And a lot of this has to do with what the Ashman evolved from, or what the gum elastic bougie originally was. And in anesthesia, quite often things were repurposed from urology, et cetera, because there were no other devices that were purposely made. Anyway, this letter summarizes how a gum elastic bougie is originally, and in the time that in my practice and when I arrived here at UK, a gum elastic bougie or Ashman had a core of polyester threads with an outside resin layer, and it was relatively stiff but flexible and had a slippery surface, as the author in this letter describes. So now the laryngeal mask airway, worthy of a chapter all of its own in Benjamin and Hagberg. This chapter, well worth reading. I'll summarize a few points and reproduce a few pictures. The LMA was invented by Dr. Archie Brain, and he started working on it in 1981. It was released commercially in the United Kingdom in 1988, and I believe about the same time in Canada, as I remember them coming into my department at that time. It was approved by the FDA only in 1991. And LMAs originally were multiple use devices and made of silicone, and the um, the classic LMA was the first device invented, and subsequently Dr. Brain invented the flexible LMA, the intubating LMA, the Pro Seal, the Supreme, and each has its own niche, and you may want to review that. There are now disposable versions of some or all of these LMAs. The LMA is a trademark term, and the LMA is specific to the laryngeal mask airway that you have been using. Now, the funny thing about the LMA is that personally, being a cardiac anesthesiologist, I often, I would very rarely have a reason to use it, and I would, use the excuse of maintaining my skills with face mask and avoid learning how to use an LMA, and was successful in avoiding how to use an LMA for many, many years. Now, the the instructions for the use of an LMA are quite specific, and if you were to research this topic, you would find that Dr. Brain has analyzed the airway in a very elegant way, and has concluded that there's maybe two ways of inserting a laryngeal mask, but there's only, the right way is the way that he recommends. Now, this these instructions for use are quite specific, and I'll leave them up here for you to peruse. And of course, if you are wondering whether or not you're being taught how to insert an LMA correctly, well, the best thing to do would be to find the instructions for use on the internet and read them, and then compare that to what you've been taught, or what you've been doing, or what you think how you've been doing it, and maybe perhaps be a bit critical of what you've been doing. Now, this is just a zoomed-in view of the recommended technique as provided in the instructions for use. I will project for you here an excerpt from the chapter that proposes that it's maybe deceptively easy to think that you are using an LMA correctly, and there are many malplacements that have been documented, and there's a lot of time and effort has gone into the design of the device, and I suspect that there is a failure rate that is not acceptable in the hands of some people who use them regularly. And I'm just, not being an expert myself in LMA, and being really believing that Dr. Brain is the expert. It's the opinion of the authors of the chapter that I'm referring you to, that there's not deep knowledge of how the LMA should be placed, and this leads to complications in the hands of people who are not critical of how it should be used. Strangely enough, the in the in academic centers, such as where you are learning your skills, operations are sometimes quite complex and very long, and it is difficult to get access to suitable simple cases. So the authors in this chapter that I refer you to actually recommend gaining your skills using it on simple, easy cases, perhaps where you would otherwise not use an LMA, before switching to your preferred airway technique, whatever it might be, such that if you were doing an open heart, well, perhaps you would practice putting an LMA in and learning the correct way of doing it. It's a funny device, at least one that, again, as I've alluded to, is one that I can't say that I am the expert in, but it in the hands of experts appears to be suitable for a lot more than the routine use in low risk ambulatory cases, and I refer you to that chapter for advanced use of LMAs, which, as you are probably aware, is the use of LMA in the ASA difficult airway algorithm is something that has evolved over time. Now, changing topics, I'm going to now provide an unsolicited plug for the difficult airway course. Now, this is actually a course that I've not taken, but I bring it up because I do know a number of the faculty, and one of the co-founders of the course is a classmate of mine, Michael F. Murphy, pictured in the center of those three faculty at the bottom right of the slide. So, as I said, this is unsolicited, and financial disclosure is warranted, and I have never received any inducement from any of these faculty. But I do recommend this airway course because I know the people involved, and I've heard good reviews from residents who have been to this course. And they also produce textbooks, which I have looked at and read chapters in, and they're excellent. So, if you're looking for a course to go to, the difficult airway course is well worthwhile. Now, this is the end of this three-part podcast, about 20 minutes per bite, and this slide is just to summarize references which I found on Clinical Key, which you all have access to, and the Otolaryngology Head and Neck Surgery textbook by Cummings, the 2015 edition, have 3 chapters in it which I think are worthwhile reading or browsing. The textbook on airway management by Benyamoff and Hagberg, copyright 2013, is superb, has many chapters, and is encyclopedic in its coverage. And finally, the chapter authored by Dr. Henderson in Miller's 7th edition is worthwhile reading. thank you for your attention, and remind you that there are uh, quiz questions for you to answer at the conclusion of this three-part podcast. Hope that these slides and hints and tips will help you in your studies, and best of luck.